Are we live? Are we live, Jenny?
Hello, we're live.
Do you like how I have a little glow for some reason on my camera today? We're just going to own it.
You do, and I wish I had that kind of a filter.
It's not a filter. We don't know what's going on. You know what? This is live, people. You know, things happen. We just go with it because we promised we'd be live. So we think it might be the laptop. We're not sure.
Well, it looks really good. I'm a little bit jealous. How do I get mine to look that way?
Wait, before we bring Dr. Steve on, I have to tell you a little story, Jenny, because I know anyone who's joining us, we want to give them time, but they will all love this story. So you remember the wedding story when I asked Brian to check if my dress was not in my undies when I got out of the Porta-John?
Oh, yes.
And do you remember how he automatically just said, yeah, you're fine?
Oh, yes.
And then what happened after that?
Well, obviously, it was not fine.
And I walked around a party in France with my dress for a couple of moments tucked into my undies. I just want you to know, I just asked Brian, can you check if there's anything up my nose before we go live?
Did you have a booger?
I'm going to ask you because, you know, he said, you're fine. And he was like, I saw you just 5 minutes ago. I was like, boogers can pop up at any moment. So you have to tell me, am I fine? Because we don't trust Brian.
I do not see a booger, but luckily you have this nice filter.
That you wouldn't see the booger anyway.
Probably
You wouldn't see the booger anyway. Well, we're very excited to have Dr. Steve join us today live again because we got a ton of questions.
As always.
Questions from us and questions from others, our listeners. And Dr. Steve's going to hop on and he's going to answer some of them. And hopefully there'll be more questions. So as you're listening today, please make sure in the comments, let us know any question you have that would be great for Dr. Steve or us on Oh Gross. There are no rules and you don't have to say anonymous or asking for a friend because I walked around a wedding with my dress in my undies, wearing granny panties that day.
Yes, and all the things we talk about on this podcast, it is a safe space.
It's a safe
space.
To
ask anything because we talk about everything.
Exactly. So without further ado, Dave, we are ready for Dr. Steve when he is ready for us. And also, Molly will be hopefully joining us later, right?
Yes.
Great.
Hey, Dr. Steve.
Hey, guys.
We're getting an echo.
From me?
Yes. So we're going to try to make sure the boys can kind of...
Okay. Thank you for giving me one more thing to worry about in my one-day kids' weddings, other than just paying for them.
Are you hearing an echo, Jenny?
Yes.
Okay. All right. We're going to hold 1 sec for tech because this is real and this is live and this is what happens. And maybe someone can text me or Jenny and let us know what's happening. Oh, they got rid of Dr. Steve. That's not what we wanted. Come back.
He'll be back.
He'll be back. I'm sure. I'm sure Dave's just going to fix it. Well, let's go over when he comes back on. He'll jump right in. But we had a question that was our very first question, actually. And it happened, I think, 3 weeks ago when we first went live. And it's taken us a while to answer it, but we're very excited. We're going to address it first. Chris wrote in and asked about when you lose your sense of smell, right, from being sick. And this is before COVID in his story. He said that, this happened for COVID for him. And he had heard that a nicotine patch can help bring your sense of smell back. So that's the first thing we're going to talk with Dr. Steve about. So Chris, if you're listening, join in and do a little wave on the comments. This is for you when Dr. Steve comes back.
That's interesting.
We hope he comes back.
I'm sure he'll be back, but I have to say I've lost my sense of smell many times when I was sick.
Yeah. I think people are more I think people also are more conscientious that they are losing their sense of smell since COVID. Does that make sense? I think many times you'd be like, that doesn't taste right, or something didn't taste right because you had a sinus infection or something. But now we all are much more hyperly aware of, right? Don't you think? Right. Losing our sense of smell. Because of COVID. But it is interesting because, and I'm going to tell Dr. Steve when he hops back on, the very first time Brian and I ever heard about this was probably in like 2007 or 8. One of our friends lost his sense of smell for like a really long time.
Okay.
Yeah.
Mm-hmm. Did they know why?
Yes. But I guess I can tell you. Let me just tell Dr. Steve too. So the funny thing was he kind of mentioned it and then mentioned it again to his roommate. And then we were all over and he mentioned it again. And we were all like, dude, you need to go see a doctor. How long has it been? He's like, I don't know, like a year. I just haven't been able to smell.
Wow.
Yeah.
So like he couldn't smell anything Just out of the blue, like this just
at
happened,
all.
like,
And then we were like, isn't things tasting weird? And he's like, I think so. Or like, you can't, because then you can't taste, if you can't smell.
yeah,
Like, or your taste is like way off, But yeah.
Ugh, that'd
Yeah.
be scary to clean out the fridge. I mean,
I know.
you wouldn't know if your milk was spoiled
Or anything.
anything.
No, So, here we go. Dr. Steve's back. Are you there? Are you there?
I am here, I believe. Yes.
Oh, great.
He's
Well,
there.
it's
No
yay.
more
Well,
echo.
we were just talking about the very first question that came in when we were live last time was about your sense of smell when you get sick. And I was just telling Jenny, Brian and I had a friend like almost 20 years ago that he had lost his sense of smell for a year and hadn't really told everybody. We were like, and when he finally told us, we were all like, okay, go to the doctor. And he went to the doctor, and it had been like it had been damaged from a chronic sinus infection that had not gone treated. Is that common?
Yeah, and I think I heard you say, and I agree, that we become much more sensitized to that and think about it more since COVID because it's just so common. Yeah, it actually is not an uncommon finding. There are all kinds of things that can cause a lack of sense of smell. The medical term is anosmia. And it can be just simply from acute kind of infection in the sinuses or chronic, sinus or nasal infections, nasal polyps, chronic allergies. It can be from head trauma, a car accident and the like, or nasal surgery. Degenerative neuro things like Parkinson's can do it. There are a lot of things that actually can cause a lack of sense of smell or a removal.
And it's called, just so I get it right for the layman like myself, anosmium?
Anosmia, A-N-O-S-M-I-A.
Anosmia. Anosmia. Oh, that's it. That's our word of the day, kids. Anosmia.
Anosmia.
So Chris was suffering from anosmia, as you could see in the comments, and he had heard that a nicotine patch could possibly help bring your sense of smell back quicker. Is that true, or why would someone think that, Dr. Steve?
Yeah. So there are no human data that really tell us that helps or is true. You got to be careful anytime you're using an actual medication that could have side effects of its own. We need to kind of be sure about it. There was, I think, as I actually looked at this, and there are actually some small studies with mice models of Parkinson's where they actually seem to improve their olfactory, which is another adjective meaning sense of smell, with nicotine. So there were some interesting little kind of sidelines that said that, but we've never really had any data in humans where that is the case.
Okay, so that could have come from that rumor, right? Or that myth, as we like to say, right? The little health myth, it could have came from that aspect of it. That's interesting. Is there anything that can help?
Interestingly, we learned in COVID, the most powerful way to get the sense of smell back is to use training. You actually use known odors and smells, and it seemed to work better if they're ones you liked. And you train your nose to realize you're smelling cherry or whatever it is that you like, lemon, things that you can train your brain. You'll say, okay, that's what that is. And after the time, and if you work hard at it and do it for a while, it actually really improved the sense of smell. There are a couple of other little oral anti-inflammatory supplements as well, something called PEA, that you could take with that in conjunction with it. But that was by far the most effective thing that really helped people gain their sense of smell back.
Oh, that's fascinating. It's almost like doing rehab, right?
Yeah, it
like
really
you would,
is exactly what it is. As if repetition with neuro stuff. The brain's an incredible machine, and it can relearn, reform, synapse, and reconnect. And so, repetitious stuff where it's able to learn, it can sort of relearn some of it. Plus, it's a good reason not to smoke, because smoking is another fairly common reason that you can lose some or all of your smell.
Here's the question for me and Jenny, though. If we lost our sense of smell and we were trying to rehab it back, are stinky boys' feet? Like, could we change our brain that we no longer smell that? If I train it, that it's good?
Well, as I mentioned, I think pleasant stuff seemed to work a little better than not. But you may, some assembly.
Could I make my brain think it is smelling nice because it's the worst when they get home from school?
Whatever
that would be bad for the public.
Not available in all states. It's whatever you like.
Well, okay. Well, then we know that one. And so the next question, Jenny and I have talked about a little bit, and I think you agree, Jenny, if you want to talk about the what's been coming up in the press about Tylenol, right? Like, it's very confusing.
Oh, yeah.
There's so much about that. And I just have to say, leading into this, and Dr. Steve, you're the expert, the only thing that I've ever heard for years and years and years is that overuse of it can cause severe liver damage, and that they've determined that half of the liver failure cases can be pointed back to overuse of acetaminophen. And that's all I've ever heard about it.
But what about the one when we were
to it?
kids? There was something else when we were kids. I can't. It begins with an R, and I almost want to say Raynaud, but it's not. Remember, there was like that syndrome. I remember there was a warning with Tylenol.
Rye syndrome, maybe?
Rye syndrome when we were kids.
Right.
What? Right? Remember that?
Yeah,
so there was like, don't give.
Sort of, that can be
Yeah.
associated with some viral infections. Well, it's to be sure that Tylenol, when somebody comes in with acute liver failure and their liver's shutting down, we check Tylenol levels, because one of the ways that can happen is an accidental or sometimes, unfortunately, intentional Tylenol overdose. That is not a good thing to try, because it is a very unpleasant situation when your liver stops working. So yeah, that can be a toxin, certainly, to the liver, which is of course an entirely different thing from the new concerns and discussions over pregnancy, though.
And just to go backwards, what is Rye syndrome, so we all can understand when we see that warning?
Yes, that's an inflammatory condition, oftentimes after things like the flu. It's why you don't use aspirin in those kind of situations. You can have a swelling of the brain and some inflammatory situations, and thankfully it's not very common anymore. But it's typically a post-viral kind of process. And again, very different from what the concerns are that have come up recently in the press.
And in those conditions, in those situations, were they recommending Tylenol is better than taking like aspirin?
Yes.
Okay.
Exactly.
After the flu. Okay. So now break us down. So what is the concern that that this is coming up in the news for us about Tylenol? What is the concern, and what's fact?
Well, obviously, the concern is that it was mentioned that the pregnant individual shouldn't take Tylenol because it's linked to autism and neurodegenerative disorders. Like everything else, it's very complicated, and a lot of genetics go into this. And, if there's one thing we should have learned in COVID, you can't start with a conclusion that you want and then try to reason back to build the blocks for it. So we have to look and see what information there actually is out there. And honestly, there are no studies that really say that Tylenol causes autism or any such. There are some studies going back to high-dose Tylenol in some animal models that suggested it might be involved in some neurodegenerative stuff. That was at pretty high doses, and we know that you can't take those kinds of doses even where that would be something that would really work. Now, more recently, there was a study that came out recently from Harvard and Mount Sinai where they studied a lot of different studies, and they combined them and looked at them. There were 46 studies, I believe it was. And they found something of an association between Tylenol use and autism and neurodegenerative problems in kids. Now, the kicker is that we have to think about what association really means. And one of the authors of some of those studies that were looked at actually objected to that conclusion, because he said, look, there's an association between violent crimes and ice cream sales. No one would suggest that violent crime is caused by ice cream sales. They both tend to be associated with hot weather, for example.
Right.
So if we take that sort of situation and apply it to the Tylenol issue, we know that high fevers, some viral infections and other things can be very damaging to the fetus in pregnancy and can lead to these kinds of things. So those people, guess what, tend to take more Tylenol for their high fevers. And it could be that, if they don't take the Tylenol, they're worse off in that regard. So then another study from a little while back, 2024, was a study in Sweden, and they looked at a lot of kids, but they did something a little bit more interesting. They compared siblings. So they were able to kind of cancel out a lot of the genetic factors and also environmental factors. And so they went with comparing one sibling who would have gotten Tylenol when they were in utero, mom took it during pregnancy, and they compared it to a sibling who did not get Tylenol. And there, the association all went away. So there was no connection in that regard. So I think it's important to emphasize that there is no causative proof or connection that we can see between Tylenol and autism or neurodegenerative problems in general. So, should moms feel guilty or afraid to take Tylenol during pregnancy? I would suggest not, because we know that high fevers and the like can cause problems. So I think that, if you have 103 fever, that's problematic, and that probably needs to be, you can do them with ice packs and the like too. But I think we're a long way from being able to conclude in any way that Tylenol causes autism.
It sounds like there's a lot to be still researched and to know just in
Well,
general.
genetics
right?
is it makes for incredibly complex situations. I mean, even when you know something causes things, take smoking and lung cancer. There are people out there that can smoke 50 years and never get lung cancer. Someone else with 5 years and they're done for it. So genetics make it always more complicated than just cause. Even when you know.
Well, there's not one. I think what we've learned, especially on this show over and over again, no matter what we're talking about, there's not like one thing fits every mold for a human, right? Because I mean, even look at Brian with his colon cancer, went through all those studies, all those tests. They said it must be genetic. Well, then it wasn't genetic. Oh, it must be, environmental. Well, it's not environmental. Oh, was he a heavy meat eater? Is he that? No. Like at the time he was, pretty much vegetarian. But again, it's just you're trying to figure out. It could be for one person something could cause a problem, and another person it doesn't, like you said.
Yeah, it's exactly right. And we have to be careful because things are so different, even things that we know about it. And that's what science is. And that's gotten so twisted around during the COVID era. Science is we make a guess at something, we test it, and it works or not, and then we go, wait a minute, we test it a little further, and you retest, and you learn things as you go. And a lot of those things, but you got to be careful to you can't jump 4 steps ahead. You have to take information as it comes and build on that. That's the only way you can really have confidence in what you're seeing.
I love that you said that because it's so important in science to also take a look at, like you were saying, all the associations that they have to consider. The control groups, what are the controls? All these different things in any sort of experiment or, trying to do any sort of study. It's so important because it's so big. It's just so big.
I'm glad
it should all be studied.
Yeah, and
we should be looking at
that because the studies that showed the association between Tylenol and autism, they weren't controlled trials. And you can't really say, okay, we're going to study and see if Tylenol causes problems, and we're going to give half the people Tylenol and half not. You can't do that. You have to.
Right.
So they're observational studies, and those are built in with a lot of statistical potential problems. So that's an important point. Yeah, controlled trials, randomized controlled trials are the gold standard, but sometimes they're hard to do, and you have to take things by bit.
Very hard to do. Yeah. And I think too, at the end of the day, everybody needs to be their own advocate. Like we're saying, Tylenol could be a problem for somebody, right? Like, I mean, you need to you have to be an advocate for yourself. You need to ask questions. You need to talk to your doctor. But we are getting fed so much information. That's what OGROS is all about. Constantly bombarded with these images on social media and everything else that it's really hard to kind of weed out, right? What is fact or fiction sometimes. And the truth is like, be your own investigator. Be curious, right, about everything.
I came to hate the phrase "follow the science," which came out a lot on both sides of it. In COVID, there's no such thing as science to follow. It's not a it's not a thing. It's a process, and
it's
you
a
have
process.
to follow that process correctly. And it's when you don't do that you begin to get conclusions that we can't really count on.
And it's ask your doctor.
Ask your doctor. Or ask multiple doctors if you don't get the answer you want, right? Like, everybody's human.
So many people don't have primary doctors now, and it's a terrible thing because it's kind of the system is kind of breaking down all over the place. Once upon a time, if you had a problem, you'd call your family doctor. They knew
your primary that you had a relationship with, who knew you, who knew how you acted. Yeah.
And that's gone away to some degree, and it needs to come back because it's how people. And I'm a specialist. Look, I'm all for specialty care, but my dad was a primary care doctor. And if you just go to specialists and don't have a primary person who's kind of the hub around those folks, you're losing something there.
Right. No, and I think that's really good advice in general because I think my husband and I were just talking about this morning. He was like, I'll just go to urgent care and get my blood work this year. And I'm like, no, we're going to go find a primary doctor again because ours passed away. But it's interesting because that's the glue. You know what I mean? That knows. I mean, our primary doctor helped Brian so much during colon cancer because we built a team because he knew us, he knew him, he knew everything, and everybody's different. And
they know when to needle you, and they know what you're not going to do that you should do, and they know where to encourage you, where to discourage you. So those are crucial elements that simply are disappearing.
And what's good, and what's good for somebody is not good for somebody else, and that's a great point. This next one's a little more fun because it flashed me and Jennie back to our childhood. Pardon me. Jackie Atkins wrote in and said, my grandma swore by Nivea cream for burns. Now, it reminded me and Jennie of Noxzema in general.
Noxzema.
We were like smelling it on our mothers and our face and everything. We're like, oh my gosh, this is Noxzema. But can you answer that and let us know it? Because I know we were having a lot of burn talk last time.
So I mean, unfortunately, that's kind of like a little bit like the butter question. Anything that you kind of put on there like that, there's just no proof. Now, it may have helped them; they do fine, but you have to be careful what you put on burns because you can increase infection risk. And kind of as we mentioned before, the only thing that's really shown to help is running cool water over that wound for 5 or 10 minutes afterwards. The idea is it's the same as resting a steak, for lack of a better example.
Right.
You want to cool it down and you want to get the tissue beneath it chilled out a bit so that it stops the burn as it goes down there. I think there was another question that asked, what about ice?
Yeah, Jared Lindy wrote in and asked, what about ice?
Right, and so you'd think that's great, but unfortunately it turns out that's kind of a bridge too far. It's maybe too much of a good thing because obviously if you put ice on your hand and don't mess with it for a while, you're going to get frostbite, and it can cause some thermal injury of its own in the opposite direction. Remember, if you put ice down on your skin, you can't tell if it's hot or cold if you don't know. And so the skin reacts kind of similarly. So it turns out that putting ice directly on a burn can actually increase the risk of skin damage afterwards. So you just want something a little milder than that. Good idea, just taken a little bit too far, probably.
So just to reiterate, whether it's Nivea, Noxzema, butter, ice, no, just put cool water on a burn. That's it.
Exactly.
And can you just feel right now the Noxzema all over your
I do.
face?
I smell it. It's
girl,
clear.
And the smell, and then it accidentally gets into your eye when you're trying to wash it
No, but it cleared
off
your
and everything.
sinuses. I mean, speaking of olfactor, it
might
would
help
clear
your
your
sense
sinuses.
of smell then, right?
Right, it did. It was like there was a refreshment to it, and also like I guess that tingling made you think that like it was working. My mom
We
swore
all
by
thought
it.
It was so great. So did my mom, and
no,
I
she
thought
took
I was awesome putting it on myself.
I mean, my mom's skin looks great, and she did use Noxzema for like 20 some years. So I'm not going to argue it.
I think
I
there's a
don't know,
Saturday Night
Megan.
Live tattoo removal skit, so that tingling means it's working if you're for this.
Totally, 100%. Well, also, fun enough, we have a lot of listeners who wrote in, but Jenny, your husband wrote in too, didn't he?
He did.
He did. Didn't he ask a question? What did he ask?
He did. I had to pull it up. Sorry, I don't have it.
Do you want me to? You know what? Actually,
Yes.
You want me to read it?
Yes.
I have it up. Okay. From first exposure to being completely symptom-free, is there a window when you are most likely to pass the disease onto others, or does it vary and depend on the virus or ailment?
Yeah, that's a great question. And you know what? Infectious disease doctors have to look things like that up because everything is very different. Look at COVID, the infectivity, the antigen positivity, they probably peak shortly after you become symptomatic. There are other things that can be contagious before you even get symptoms. There are things that can be contagious for days to weeks. If you're exposed to chickenpox, you don't even come down with it for a week to 3 weeks. That's when you don't even have to start staying away from work if you're at risk for it for a few days because you don't come down with it that fast. So every disease is in fact very, very different. In addition to severity, and in addition to the, as we mentioned, genetic susceptibilities that people have and how sick they're going to get with those illnesses, there's a very big difference from disease to disease and sometimes from person to person with it. When you get sick, how long you shed that virus. And in terms of person to person, if you're an immunosuppressed person, you might shed, we had someone with COVID that shed that virus for weeks and weeks and weeks.
I was positive. The first time I had COVID, I was positive for 18 days.
Yeah.
Ooh.
My wife was positive for 14 as well. And,
yeah, 18 days.
But this person was positive for months.
Okay,
This was a stem cell bone marrow transplant patient.
Oh, okay.
If you're a person that doesn't have good immunity, that virus may kick along for a long time.
A long time.
So the variability is beyond even what your husband was thinking about. It's that much more complex even. So it's a very, very complicated issue. And we look it up all the time when we take care of people.
He asked that.
Why did he ask that?
Okay, so Dr. Steve, this is why he asked this. Because he came home several weeks ago hacking and feeling awful and then getting a little bit worse. I said, you should probably test for COVID or, go get yourself tested. Oh, no, I'm going to go sweat it out, in the sauna at the gym.
Oh, that's like a Brian.
So,
Brian would say that. I'm going to sweat it out.
So about 5 or 6 days later, I got sick, really sick. And I was sick for like 2 weeks. And the boys got sick. Now, they were only sick for like maybe 2 or 3 days apiece. But he got the whole family sick. And so we were having an argument about his
what the
hacking
window
and his
was?
germ
Oh, I
spreading.
love that. I love that.
And
I love
so
it.
that's why he had to ask Dr. Steve
That's a
that
question. And also, like, when you're in a room, like, I know there's no exact answer, but also, like, don't you feel this, like, you're in a room or you're at the movies and someone starts hacking next to you? I'm always wondering, like, right, and you're like, how many days until I know if this affected me or not, right? Like, what is my, like, window that I can feel I'm okay?
Yeah. So there are a lot of variables there too. A lot of things don't pass very well across 8 or 10 feet. Remember, there was the debate about how far you have to be between each other, for COVID, but it does spread in air and some currents and so forth. Now, interestingly, bacterial infections, bronchitis and the like, they don't pass as efficiently typically through the air. There's this disease called mycoplasma, which used to be called the walking pneumonia, and it will percolate.
I had walking pneumonia when I was younger.
Yeah, and so a lot of those are mycoplasma, and it spreads through a family by weeks. And so one person will get sick and have a cough and feel kind of bad. They may not be terribly sick with it. They still are able to go back and do their business. And then another member of the family gets sick a week or two later, and then it'll march through a family very slowly like that. So again, it's very much disease dependent.
And that's called mycoplasma?
Myco, M-Y-C-O.
Myco, not micro. Because I was thinking tiny. Myco.
Yeah.
Oh, myco. Like, I got it. Okay.
To be sure, but yeah, so mycoplasma. And it'll just kind of march slowly through family units but then you have measles that you can have measles and somebody will cough up in the air and they can leave the room for an hour and you can walk
that
in
freaks
and
me
get
out.
it.
Yeah.
So that's so many
really scary
variables about that. And where it comes into my line of work a lot is somebody will have a particular kind of respiratory virus. And you'll say, okay, we're going to isolate that person because they're around other patients that might get really sick from it. How long do you leave them in isolation in the hospital? And it's very disease dependent. That's why the CDC has a particular graph and page with every disease and community.
Right, it's all depends on
what kind of isolation and how long you keep it. And it's helpful to consult that to make sure you're doing that right because you don't want to expose other people.
So for all the hypochondriacs listening, what you've just told us is that like 14 days later you could still get sick depending on what it is. And then I love that you coughed psychosomatically.
Yeah. Full disclosure, I had COVID about 3 weeks ago.
You did. And you gave it to Dave, our producer, over the phone. They both came down with COVID the same day. They live in different states. We're trying to figure it out.
Mode of transmission, but
so apparently this is a new rumor right here in Oak Grove. You can get
But
COVID
most viral infections like that, when you think of respiratory illnesses, they're going to transmit in a few days.
So normally it's a few days. Yeah.
If you're going to get it, you will have gotten it within a week for most things.
Most things. Okay, that's good. So we can definitely blame your husband for you getting sick.
We can definitely blame Sean for that.
Yep. And is Molly available? Because I know we only have 5 more minutes left, so I want to see if Molly can hop on because
she should be.
Yeah, let's see if we can get her on because we have a funny story for you, Dr. Steve, and one more question. And we've got so many more questions we know, guys, and we will get to it our next live. But we're going to hit one more up right now, and we'll see if Molly can hop on. It's pretty funny this morning. So Molly's birthday was on Monday. So happy birthday to Molly. Molly, happy birthday.
Happy birthday, Molly.
Hello, Molly.
Thank you. Hello. How is everyone?
Great. We're happy you're here.
Thank you. I did just want to say really quickly, there is Noxzema.
Oh, you found you were listening. Yay.
I found it. Yes, Noxzema is still available in case anyone's wondering.
Where is anybody? I'm already seeing the next So Gross Live. We have it on.
Yes.
Oh no, I loved how it felt.
It felt great.
Love it?
Oh my gosh, it's going to clear up our sinuses. Me and Jennie are always so stuffy with our allergies.
Yes. So it is available. Yes.
So Molly's birthday was this week, Monday, Dr. Steve, and we sent her some cupcakes. But we want to start this conversation by her telling what came at the same time as her cupcakes.
So this morning I get a knock on the door, and it's not one but 2 packages. It was the lovely cupcakes from the team, which thank you very much for that. But also I did receive a package of Cologuard. So it is that time to do the Cologuard. But it was just crazy that they both arrived at the same time.
Well, right. And we've talked about that topic.
Yeah, we want to explain to the live audience right now what Cologuard is.
So it's a test that you can it's a stool test that you can mail off and get a result. And I think of all the things to talk about that, the Cologuard take-home question is that it's really only for people with kind of mild to moderate risk. If you're a high-risk person for colon cancer, you should get your colonoscopy. I mean, nothing against Cologuard. For my money, I had a colonoscopy. And so it certainly is a reasonable thing to do. A lot of people just won't get a colonoscopy. And I was late getting my first screen colonoscopy. Again, full disclosure, just didn't get around to it, which is what a lot of people do. And that can be deadly if you don't get around to it. And so if you're not going to go do the other, it's great. Or if you're low to moderate risk, it's a reasonable thing to do because it does screen for some of those mutations and can see the colon cancer sometimes. But if you're a higher risk person, family history, those kind of things, it's probably ideal to go ahead and get a colonoscopy and see a gastroenterologist.
And it's good at least if you're not going to do that, at least do this, even if it comes with the birthday cupcakes. I mean, I'm just seeing a visual.
Not necessarily in that order.
On that, speaking of getting older, on that note, we were all in a text group texting and asking about. We were talking about vaccines in general, but what came up is that shingles vaccine. It was between the three of us on different text chains about the shingles vaccine, and I know that Molly, you've been recommended to get it, right? You were saying.
Yes, I had chickenpox when I was younger.
Me too.
So I have known people that have had shingles, and it actually terrifies me to see what they've gone through. So I know I need to schedule my vaccine soon because I do not want to go through what they've gone through previously.
Yeah. Well, everybody had chickenpox when I was younger. So
well, I got it when I was 16. So it was in every.
That's rough now. That can be.
It was.
Rough.
It was
It's really rough.
everywhere, and I won't go into detail. It's not that kind of show.
Parties where there'd be a block party and all the parents.
And they would give it to all the kids. Yeah, I didn't get it till 16, and my mom made sure my sisters remaining who did not have it at that point, who were much younger, she made sure everybody else in the household got it because it was so bad for me at 16 that I am too afraid of shingles. But maybe Dr. Steve, you can explain why people who had chickenpox are, what the correlation is and why this vaccine is even recommended.
So the virus is called VZV, or varicella zoster virus. If we sort of take that into the vernacular, it's the chickenpox shingles virus, because varicella means chickenpox, zoster means shingles. If you just sort of see those words thrown out there, so you have to have had chickenpox before you can get shingles, because by definition, chickenpox is the first time you get the virus. And then it stays in your dorsal root ganglia, your sensory ganglia under the skin, along the nerves, and later on in life, whether it's some sort of stressor, or if you take steroids, become immunosuppressed, or if you just live long enough to get older and have increased risk of these things, your immune system kind of what we call immune senescence. It drifts downstream over the years in effectiveness. And so people break out with shingles. And as you point out, Molly, it can be terrible. It can be debilitatingly painful. Now, I see people have very little pain, a little itching, and barely see anything. Thankful for them. But it can be debilitating pain, burning. It never stops. It's that horrible electric kind of neuro pain. It can even involve your eyes and cause blindness in some situations.
Oh wow.
We see it. So it's a disease that can be quite awful. And it turns out that we have now a newer and better and really good vaccine called Shingrix, and you get it a few months apart depending on what kind of patient you are, and it's very good at protecting against that outbreak of shingles. Now, it's recommended at age 50. Why 50? Well, it turns out that if you give it at 50, you're just getting into that zone where you have more and worse cases of shingles as you get on past that age group. And you still have great immune response to the vaccine. Whereas if it's 97% protective over several years, 4 or 5 years, whereas if you wait till 75 or so, that protection goes down to 90%. Still very good, but not as good. It's kind of like, all airliners fly between 30 and 40,000 feet because you want to get above the wind resistance and the weather, but you still want to have enough oxygen to burn the fuel. You're going against two different things, but it turns out that both of them align similarly. You're about to get into a time where you need it more, but you're still at a time where it works the best.
The best long term. And interesting enough, go ahead.
Are there any side effects to the vaccine?
Well, I won't lie. It is one of the more irritating vaccines.
Great.
It does have some significant side effects. For a normal immune system person, you take 2 vaccines. One is 2 to 6 months after the first one. And particularly with the second vaccine, You can have significant soreness at the site. You can have diffuse muscle aches. You can have a little fever. You can feel pretty bad for a day or two, sometimes after that. And so, but nothing of typical any seriousness, and well worth it if you've ever had a bad case of shingles.
And this is, I'm sorry, we have a live question that just came in, and I'm just going to piggyback on it. It's kind of in general about viruses, but since you're talking about the vaccines, this person is saying that they have seen more and more folks say that they are getting sudden deafness overnight, and they're blaming it on viruses. Have you seen hearing being affected from viruses in general?
Yeah, you can. In fact, you can even see it from shingles, interestingly.
That's why I thought it was going to correlate, because I heard that about shingles. Yes, can you explain that, Mark?
It can involve the cranial nerves, and so there are some syndromes where you can get an outbreak on the face, and you can lose hearing. There are others that can make the hearing hyperacute. So yes, it and potentially other things can involve, but the shingles can involve focal hearing in one ear.
Oh wow!
And you can see some little blisters inside the ear. And you actually see the blisters there, and that's where you see it.
Ooh. Well, I know
that's awful.
Yeah, exactly. On that note, I hate to.
I'm going to go get my vaccine.
Exactly. And I know we have to have a bigger. We have to wrap out our live right now, but I want to say that there probably is even a bigger discussion, because we were doing this on the side chain between all of us, just about. Thoughts on this, a little more thoughts on this vaccine that I think was very helpful, Dr. Steve. You had some information, so we will continue this conversation next time we all hop back on. But what you've told us right now, me and Molly are, well, I got another year, guys, before I'm 50, just so you know, just one more year. But I'm the young one of the group now. But I will be running on my birthday after this conversation. Because that. But thank you so much, Dr. Steve, for hopping on live. Molly, I know you were crazy busy at the clinic today. Thank you for hopping on in the middle of all this.
Absolutely.
And we will all be back soon, and join us, because we're going to be doing more of these lives.
Thanks, Dr. Steve.
Thanks,
Thank
guys.
you, Dr. Steve.
Good to be with you always.